Kia ora koutou. Tonight we'll be concentrating on the management of adult diabetes predominantly, in particular acute problems, but also with some focus on long-term management of diabetes. Thank you to everyone for your ongoing attendance at our webinars and your support and the positive feedback we receive. We do take your feedback on board. The last two webinars, people have suggested we need to have even more of a rural focus and experts who thoroughly understand the context we work in. Tonight, our two experts fully fulfill that criteria. We're very fortunate to be joined by clinical nurse specialist Sharon Sandilands and Dr. Alex McCleod. Sharon works down in Central Otago, based at Dunstan Hospital, and does a magnificent job of caring for diabetic patients right the way through Central Otago, Queenstown, Wanaka, Alex, and the surrounding districts. She has an excellent relationship with her patients and is a much valued resource person for local doctors and nurses alike. And I'm sure Gary would back me up on that. I see you there, Gary. Alex is a rural specialist and GP who I'm very lucky to work with at Taupo Hospital. Alex has a special interest in diabetes and a depth of knowledge. Alex has given me permission to share that he is in fact a type 1 diabetic himself, and he was diagnosed at the age of 30. His clinical knowledge is backed up by real-world experience that gives his teaching extra credibility. And in fact, it was a teaching session at Taupo Hospital that inspired me to do a topic of diabetes with this webinar and invite Alex along tonight. So just before we get underway, I'll explain a little bit about tonight. The structure of the webinar is going to be slightly different for those who have come to our webinars before. Alex is going to present two of his own cases and we'll have a bit of a discussion about diagnostic and management dilemmas. We're also going to run a few brief polls for all participants to take part in. And don't worry, these will be completely anonymous, so no one will be able to pin your answer to you. It's just really to gauge an idea of people's thoughts about different aspects of management, and Alex will reflect back on those. We will then move on to discuss some aspects of acute management with Sharon and Alex using a few brief case vignettes. And finally, Alex will briefly discuss some of the newer agents used in the management of type 2 diabetes, recognising we don't need to have an in-depth knowledge of these, but an awareness, and certainly there are some new ones coming on the scene. So please feel free to keep your questions and comments coming, typing them into the chat box, and Gary will keep an eye on these. We'll aim for the webinar to be about 60 minutes, but we may spill over in time. Please feel free to move on after an hour and carry on with your evening if you need to, remembering these are recorded and available to view and listen to later. Finally, if you just keep yourselves muted throughout, that just improves our sound quality. And there's a survey to complete. The link for this is in the chat box, and this is a way of you providing your medical council number so that I can register for your CME points, and it gives an opportunity for you to provide feedback.
Thanks, Matilda. Tēnā koutou katoa. Thanks very much for the opportunity, everyone, to talk tonight about this. I'm hoping this will be useful for everybody, and obviously I'm aware of being a little bit biased towards the topic myself with my personal experience as Matilda has outlined, but we hope this will be fairly objective, and by bringing in some real life cases from our own practice, that it will be sort of applicable to the environments that we work in, acknowledging though that all rural hospital settings are a bit different, and so I guess everything needs to be taken with a grain of salt. Before I start on just presenting some cases, I just want to acknowledge also that obviously we are doing a bit of a snapshot of a very large topic today, and diabetes is very much a long-term condition, and therefore all of us need to be mindful of the thrust that should carry with it when we're seeing patients who are diabetic in our hospitals. But we're trying here to focus on some matters with respect to acute problem troubleshooting, I guess. So hopefully this is helpful, and we certainly don't want to be telling you how to suck eggs, so to speak. So let me tell you about this case just to introduce things. So a 63-year-old Pakeha man that came to our Taupo Hospital ED on a Thursday evening. So he came to our attention because he'd had some blood tests taken in primary care for rather vague symptoms of malaise and weight loss, and had a random glucose identified of 44. So with the benefit of the hindsight of knowing the lab result, he came to the ED, and this kind of clinical presentation was brought forward to us of relatively typical diabetes symptoms indicating quite marked hyperglycemia constantly. And as you can see, examination, vital signs fairly unremarkable, and a capillary blood glucose of 30 and non-ketotic. So he had some blood tests taken. They were all normal, including his blood gases and acid-base balance. So really it came down to what should we do with a chap like this in a rural hospital ED in the evening, so after hours. What's the diagnosis first up? Well, does it matter? Not necessarily at that point in time. And what is our overall strategy and acuity that we're going to employ here? So we have the options in Taupo of utilising a rural hospital medicine clinic that we run on a Friday, and that's has ability to link in some clinical nurse specialist support, or other options are to admit this chap either to us in the rural hospital or transfer him to our base hospital in Rotorua. So tonight, I guess the question was, does he get immediately transferred and a road ambulance pulled off to do that job for us up to the base hospital? Does he stay in our rural hospital in our ED or go to our ward? You know, how appropriate is that for something that's a relatively rare situation to deal with? Does he just go home? Does he need anything done, any particular treatments at this point in time? So this brings us to our first poll. Please, Matilda.
So the questions there, I'm sure everyone can read them. So first of all, just would you think this was type 1 or type 2 diabetes? And then everyone's just deciding on whether or not it would be an admission to your rural hospital. So think about your context, a transfer to the hospital that you would refer to, or a discharge home with a management plan as an outpatient. Maybe, Alex, just one more bit of clinical information. You said that he'd lost 8 kilograms. Roughly what kind of weight was this chap? A big guy, little guy?
Yeah, he was lean.
Lean, okay.
And interesting to see the group favouring a diagnosis of type 2 diabetes here. So this man had type 1 diabetes, and this is quite a typical presentation and serves to demonstrate to us that type 1 diabetes can, the onset of that can occur at any age. There's actually a second peak of incidence that occurs in older adults. Part 2 of the question, where do we admit him to or transfer him to? So all quite reasonable options, and I guess it just depends on clinician sort of experience and confidence, really. This bloke was managed by me, and I sent him home for the evening and brought him back the next day to transfer him to the base hospital for essentially initiation of insulin and setting him up on more of a longer term plan.
So I'd say our group, when Alex did this presentation to our group, we all certainly thought this was a type 2 diabetic, and was one of the key learning points for us, certainly biased by his age.
Yeah. So just talking about diabetes in rural hospitals, it's almost never a primary problem that leads to people being hospitalised. It's fairly rare, but it frequently is a contributor or etiological factor in diseases that we see. I guess, when we delve into the increasing incidence, particularly of type 2 diabetes, is a lot to say for, the typical milieu of genetics and environmental factors in terms of our increasing sedentary nature, our food systems that, are heavily weighted towards quite processed foods, etc., and our health system that is not necessarily all that well set up to cope with people with a condition such as this. And I've put there a bit of food for thought really about whether or not rural hospitals ultimately are suitable environments to manage diabetic emergencies such as DK and HHS, which require quite a lot of intensive monitoring and intervention. And for something that's not common to come through a rural hospital, arguably, uh, is not necessarily the safest place in which to undertake that exercise. Again, depends from one location to the next on how it goes. And I've just thrown in there that caring for children with these kind of problems is even more nuanced. I wonder if Sharon just wants to jump in there and offer any thoughts on that particular aspect of things.
So I guess usually the children would have type 1 if they were unwell, admitted to rural hospitals, so they'd likely be on an insulin pump. And of course, we'd be ketone testing and that sort of thing, but certainly with paediatric support from base hospital. That's what you'd be looking for at your hospital, Alex?
Yeah, absolutely. So I guess the point I want to make here is that a lot of the children out there are on pumps and continuous monitors and have a very close working relationship usually with their diabetic nurse specialists and the specialist centres that they have come to be, treated by. And a lot of the problems they encounter will be able to be identified and managed in their own homes, let alone needing any contact with the rural hospital environment. So just make sure you clearly delve into where things are at as far as the sort of main treating team with children especially, who are often heavily involved in a particular system already. So I'll move on to another case we've got. So again, another real life case from Taupo. Came through the middle of the night. So I saw this chap, a young middle-aged Māori man. Vague presentation of dyspnea, bit of a cough, no fever. Just maybe a week or two before we hit COVID level 4. So we were starting to be wary of people with acute respiratory illnesses and the implications that might have on our overall management of them. He's got an interesting background, this guy, quite a lot of pathology for a man of 39. The main ones I've emphasised there: chronic heart failure and atrial fibrillation. What might be said as poorly controlled diabetes based on his high A1C. A usual package of meds, including 3 different oral anti-diabetic medications, and he was meant to be taking sotalol, but not. Hadn't been taking rather for 1 to 2 months from some misunderstanding from a consult with a specialist. He didn't appear particularly unwell. There's nothing really to find on examination, except for notable vital signs with quite a marked tachycardia and atrial fibrillation. Mildly tachypneic, but in no means distressed and oxygenating seemingly well. What would the group think we need to do with a chap like this at this point in time? What might be the first investigation we would go to? Let's have a poll on that.
Guys, I think that's a good response.
Yeah, indeed. I think everyone's on the money there, really. That important thing is to look at this chap's acid-base balance now and what his glucose levels are doing. So I was the doctor looking after this man at 3 o'clock in the morning in Taupo, and I guess I hope that I can have the group here learn from my mistakes, and as is the classical trap with atrial fibrillation, I proceeded just to get on and manage the rapid AF because I thought that was the primary issue. And so we gave him some oral, then IV metoprolol, and then some IV diltiazem because nothing much was happening. We made his dyspnea and cough a little worse, but he still wasn't wheezy. So thinking that maybe we'd just embarrassed his pulmonary vasculature, we gave him some diuretic there. And after 2 to 3 hours, things were looking a little better. His heart rate had come down eventually to 110, 120. and figured it was reasonable to get him home and check his blood tests at 8 o'clock in the morning when they were processed by the lab and see what we found. But of course, as everyone else in the group would have done, we should have checked his bloods and his blood gas, because he came back to the hospital at about 8:30 in the morning and was still mentating fine, but his blood pressure was down a bit, unsurprisingly. And he had this metabolic picture on his blood gases and blood tests. So a real mixed bag of possible explanations for what was going on here. So we've got a metabolic acidosis that would appear to be somewhat chronic in view of a bicarb that's down a bit. Lactate also raised, which might be a sign of hypoperfusion somewhere. That could be his meds coupled with the heart failure background. It could be the metformin that he's on. Maybe it's sepsis starting to develop in light of the white cell count that's raised. Is it just he's got acute kidney injury for whatever reasons, but dehydrated? Also had some liver impairment evident by way of his raised bilirubin. Not ketotic, interestingly. So he doesn't really meet criteria for being in diabetic ketoacidosis. You certainly could be in hyperosmotic hyperglycemic syndrome. And that's what we're going to move on to next. So ultimately, I part of us wondered whether this was just a weird presentation of COVID-19, or was it really just a manifestation of his poorly controlled diabetes getting all out of hand for a variety of different coexisting pathologies. So I thought I'd just include this slide. I've ripped it straight from Up to Date about diabetic ketoacidosis and HHS. They overlap a little, and that's really what I wanted to emphasize in this presentation, that we need to not get too hung up on trying to meet the exact criteria of one or the other. And oftentimes for these sorts of people with poorly controlled diabetes, it's going to be much more likely to be a HHS situation. It produces a much more profound metabolic derangement and dehydration picture, and it occurs much more gradually. So in light of that, we all need to focus on thinking about treating it and correcting the pathophysiology gradually, and you know, in terms of large volumes of fluid replacement over a gradual period of time. So I don't really want to go into the nuances of different protocols at different institutions, and my understanding of the evidence base is that the best thing is just to learn your local protocol and be familiar with it and play it out if these sorts of patients come along. Because
so
of the... Yeah.
Alex, can I just double check with you? So HHS used to be called HONC. Am I correct in thinking that?
Yes, precisely.
Yep. And if we were to have a suspicion of that, which I guess is the important thing, is to have it on your radar and your differentials, what would you say would be the single most useful test or calculation to do to, obviously it's a cluster of things, but when it comes to differentiating it from DKA, what important tests should we add on or calculate that we might otherwise not think of doing?
Yeah, thanks, Matilda. So the thing to emphasize about HHS is that people have much higher glucose levels. So looking up here at the glucose levels that you see in each of these conditions in our unit. So HHS typically will have very high glucose levels, and people are profoundly dehydrated with it. They're not acidotic. They've been in the situation for a little while, and they've compensated by dropping their bicarbonate. And they're not ketotic either, is the other main thing to emphasize there. You can obviously work out the serum osmolality, but I think on the whole, it's not a particularly strong differentiator between DKA and HHS, even though it is part of the terminology that we use for defining the condition of hyperosmotic osmolar syndrome. So there are, at the bottom of the slide, as you can see, means of calculating a serum osmolality, should you wish to, and there's plenty of other means of accessing those sort of calculations around as well.
And I think I recall, and they're quite high risk of of forming blood clots, aren't they? You need to be really careful with their
Yep.
DVT prophylaxis.
Correct. All of which is almost always well
In a
outlined
protocol.
in a protocol, and I'd encourage everyone to just have a good look at that. So moving along, I wanted to just touch on one of the things about caring for diabetic patients in hospitals is really good monitoring. And one thing that Aussies do a lot better than us is that they have rolled out 3 years ago this, or 3 to 5 years ago, I believe, this really neat chart that allows glucose levels to be plotted in and action to be taken at the bedside immediately when blood sugars get out of range. And the insulin charting is all done on the same pro forma, so that a sort of more holistic means of monitoring a diabetes situation can be achieved than we see in a lot of our systems we have in New Zealand. So I've been hoping to try and push this through for our hospital, but of course it comes with challenges in terms of clinical governance requirements, etc. But I'd encourage everyone to have a look at this, just because it outlines really nicely what to do as means of tidying up glucose control for people where it's getting out of range, and we'll come to the front side of this chart in a moment as well. I thought I'd just ask Sharon also to speak to us about glucose monitors now, because obviously diabetic control is inherent on seeing what the glucose levels are and treating accordingly. So I'm going to throw up a slide of a whole lot of different monitoring systems that now exist and are used in New Zealand, and ask if Sharon just wants to talk us through what she sees of these and some of the little ins and outs.
So most people, of course, still use the CareSense monitors, which are funded in New Zealand, and a lot of them have got Bluetooth functionality, which people really like to use the trend graphs on their phones, etc. And most people find that really useful and helpful. So that's all funded. And then, as you can see there, we've got these continuous monitors you're probably quite familiar with on the top right there, if you can see my arrow. This one's called the Freestyle Libre monitoring. Yeah, thanks. And so people put the sensor on their arm and it stays there for 2 weeks, and people can just use a scanner or a phone app, and it is taking blood sugars every 5 minutes, so it gives you a graph, a continuous graph of what's happening, which is really useful for the patient for their own learning as to how to manage their diabetes, and also for us diabetes nurses to be able to instruct on insulin doses. And then down to the bottom left, we're starting to look at pumps and continuous monitors. So that's a Dexcom monitor on the bottom left. And this is works in conjunction or on its own with a pump, and the same scenario, it's taking blood sugars every 5 minutes and gives the person a graph. It also gives alarms when a blood sugar is trending low, so that a person can realise as they're approaching low that they need to do something about it. And it now works with the tandem pump in that, which is really good for children, it will now suspend the insulin if the person is trending into a hypo. That's what we call basal IQ, and this is now available here in New Zealand. And then we've got that transmitter lasts for 3 months, and the sensor is worn in the skin for 10 days. So same system as with Libre monitoring, we can only use those sensors for about 2 weeks. And both of those are unfunded. So the Libre costs $100 for 2 weeks, and the Dexcom system slightly more. So that has quite a big effect for a lot of people.
So Sharon, does anyone meet any kind of like special authority that they do get them funded, or it's all personally funded?
It's all personally funded.
Yep.
Yeah. A lot of parents with children get funding from different trusts for continuous monitors.
Yeah. Are there any systems that link in the glucose monitoring to the pump so that it will change the infusion rate of the insulin from the pump?
Currently, we've just got the basal IQ, which will suspend the pump for going into low.
Sure.
But by the end of the year, we're going to have what's called control IQ, which will also get the pump delivering more insulin for. So then we've basically got a closed loop system.
Yep, sure. Thanks, Sharon. I've seen a few questions come through, but I'm just going to ask one myself for Alex. Thanks for bravely disclosing your case, Alex. I like it that the diabetic doctor even didn't think of checking the blood glucose, and we're all fallible. So thanks for sharing that case. And then something that you mentioned, and I may have got it wrong in my head, but with the first case, I remember when you presented that to us, you mentioned something about the level of that chap's blood glucose that influenced your diagnosis of him.
Yeah, sure, Matilda. So one thing to say is let's just come back to that first case. So someone who's got a glucose of 44 and has had symptomatically a rapid change is highly likely to be type 1. Just that picture is suggesting to you just a pronounced pancreatic failure to be able to get your glucose levels up into that kind of range and in just a short space of time like that. So the other sort of aspects to a phenotype, as I said to you earlier, he's a lean guy who's Pakeha as well, and he's not showing any other sort of features of metabolic syndrome really. So those are probably the main things to emphasise there as to leading you down that pathway.
Yep, sure. I think we'll just go over to Gary. I've just spotted a few questions coming up in the chat box. Gary, are you happy to feedback some of those questions to us?
I think probably Alex has done actually quite a good job of covering some of them anyway. There was one question there for Sharon about the costs of some of those continuous monitoring systems, if someone is going to consider purchasing it themselves.
Yes, so Freestyle Libre people purchase online, and yeah, I saw a comment there about disparity. Yeah, it's only for those that can afford them currently. I believe that they're becoming funded now in Australia, and people are lobbying Pharmac for funding for it, especially for children.
And Alex, there's a question there from Matt, which I think probably what Matt's getting at is, and he might want to ask the question himself, but is largely around another area where I guess type 1 and type 2 can be confusing, where just very high blood sugar levels can in themselves be toxic to beta cells, and therefore you can start to get a ketoacidosis and almost a type 1 picture. Do you want to comment on that?
Yeah, no, Matt, you're exactly right there, Matt. And that in itself produces a interesting phenomenon called honeymoon syndrome. So oftentimes when people with really high glucose levels start onto insulin and they give their pancreas a rest from the glucose toxicity that it's been suffering, that the pancreas will actually recover and start to function quite well again. And so most, or rather a lot of new type 1 diabetics will come off insulin or markedly reduce down their dosing requirements for a period of time in what's called the honeymoon phase before things then further go downhill and they have to restart or wind back up again to a full dose. So yeah, so it's exactly right, and it's part of the pathophysiology, unfortunately.
So Alex, I'm just clarifying, this is new to me. So the hyperglycemia is actually directly toxic to the pancreas and impairs its function.
Correct.
In a loop.
Yep.
So one of the other comments Matt has made with regard to that, he said with the first case, if it was type 1, would you not expect a higher ketone rise if pancreatic failure? So maybe he's asking, why had this patient not tipped into DKA at this point, perhaps?
Yeah, fair enough. I guess he's just managed to present at a point at which his body was still producing just enough insulin as to not end up needing to become dependent on ketones. Yeah, that's really about all you can say there.
Yeah, and I guess just enough to be suppressing ketone production, is that going into that cycle.
Yep.
If there's no more questions at this point, thank you, Sharon, for commenting on the glucose monitoring. I think we'll move on to our case fig next, but do keep popping the questions into the chat box. That's really great. So if I just go, I think we're often faced with situations where, with type 1 diabetics coming in who have an acute illness going on, and the acute illness, whether it be pneumonia or pyelonephritis, is the reason they're coming into hospital, but their diabetes has gone a little bit out of whack, and so that's a secondary thing that we need to manage. And I always feel like I'm guessing a bit, and I'm never that comfortable managing that side of things. So I thought I'd just provide some scenarios to Alex and Sharon that we'll talk through, just to talk about that management of the diabetes that's gone off the rails a bit because of the acute illness. So the first chap I would describe to you as a 58-year-old man who's got long-standing type 2 diabetes. He's 100 kilograms and he's on metformin only. So he's admitted to our hospital, our rural hospital, with pneumonia, but he's noted to have high sugars running in the 20s. So then I'm like, oh, what am I going to do about his diabetes? I can sort his pneumonia out. What am I going to do about these sugars for the night? So I'll just sort of, I'll go between the two of you, and you can disagree with each other if you wish. But Sharon, in this situation with this chap, would you stop his metformin or carry on?
In general, I tend to think that in the acutely unwell person, it's the safest thing to stop metformin.
Mm-hmm.
And I think we don't know what his HbA1c was. That would be interesting to know.
Yep.
About his control in general.
So,
but he's acutely unwell. I would stop his metformin and give him some insulin.
Yep. So what could be the downside of leaving someone on their metformin when they were unwell?
Generally, it's just another factor to worry about if they've got a deteriorating renal function.
Yep.
It's just one less thing to have to worry about. But we do have to be aware when that person's discharged that they restart it. So we have to remember that. Yeah.
Yep, sure. So if you mentioned there that you think it would be appropriate to start some insulation, my goodness, I'm thinking about home renovations like dominating my mind. You're thinking about his insulin. How might you start that, Sharon? Are we looking at a sliding scale? Would I be using Act Rapid, Novo Rapid? And then I think, Alex, I'll hand over to you to sort of try and help me figure out what the heck to do with dosing.
So in the past, we've used what's been called sliding scales, which Alex and I, we've just generally been discussing this a wee bit. They're a bit retrospective. And if we talk about correction, we're talking about prospective. So we're looking to give people a correction that's going to improve the glycemia going ahead rather than retrospectively. And we use shorter acting insulin rather than the subcut Act Rapid, which was used historically, but we generally just use it in infusions now.
So I know that was one of the things I really learned from you when I was working at Dunstan Hospital, when I was happily prescribing Act Rapid, and you were like, no, please use Novo Rapid. So would you mind just describing a bit about the difference between Act Rapid and Novo Rapid? And Alex, I'm not sure if you had a corresponding slide to go with
Alex
that.
has got a really good slide. So the profile of Act Rapid is that it works for 6 or 8 hours, so it's completely not physiological.
Okay.
Whereas Novo Rapid or Apedra or Humalog are quick acting and have an action of 3 hours.
Mm-hmm.
So we use those at meal times generally.
Mm-hmm.
And I'll let you explain your slide, Alex.
Yeah, sure. So the notable thing is that no insulin that we have available to us commercially is anywhere near as good as what our pancreases can produce endogenously. So looking at this graph here, you see that when you eat and you need some insulin effect in your body, your pancreas is able to produce it in a really good spike quickly and effectively, whereas even our fastest rapid acting insulins take a good hour or so to reach their peak, and then they'll fall off over a period of time of sort of, we consider most of the time 4 hours to be sort of down to a relatively negligible effect again.
So you're sort of meaning like Nova Rapid?
Correct.
As an example of that.
Yep. You can see here this yellow line that I'm indicating now is what is done by Act Rapid. So it reaches a later and lower peak. So it's just not nearly as effective at managing the spike in glucose levels that we see from typical meals that we eat, or for trying to get blood sugars back in range when they're already high. Some of the points here I just want to emphasize to the group is that really what we need to try and do when we give people insulin is to match it to what their glucose profile is doing at any one time. Let me just bring you to the slide before, showing you that when you eat, even in normal healthy metabolism, this solid red line here that I'm indicating shows you what your blood sugar does with typical Western food eaten at the 3 meal times in a day. Okay, so everybody gets a bit of a spike. If you compare the graph on the right, the scale has been changed such that people who are non-diabetic get a spike, but it stays within physiological range. People with diabetes either sit constantly high and get an accentuated spike with that, or type 1ers tend to get a profound spike. And this is what you're trying to manage by giving exogenous insulin to offset that issue. Okay, so as you can see, that the spikes need to be matched by insulin if at all possible, and none of our insulins really are able to perform to quite that extent, unfortunately. So we have to use things like making sure that the dose timing and the dose amount is as good as it can be. There are a variety of means of achieving that. So it's important to make sure that doses are given actually pre-meal and the insulin can start working. To be considerate of the different sensitivities that individual patients might have. So type 2 diabetes is the hallmark of it is insulin resistance, and so they're going to take a lot more insulin to achieve the same effect to their glucose levels. And most people who are savvy with basal bolus regimes will slowly learn how to do flexible dosing according to all these factors that I've listed here, which impact on your degree of sensitivity to insulin. And you need to carb count and work out using your sensitivity factor and your correction factors what your dose is going to be at any one time. So that's all getting a bit complicated. And what I want to just highlight to us is back on the chart from Australia, for example, where it basically walks you through how to do it here by saying, if you were to take a starting dose of a person's weight in kilos divided by 4, that would give you the basal amount. Okay, what this tries to do is use a dose of 0.5 units per kilo as the total daily dose required of insulin to manage this person's hyperglycemia. And they split it 50-50 into the basal amount and the mealtime dosing. And therefore, your weight divided by 4 is 0.25 or half of that 0.5 units per kilo per day amount. And the mealtime dosing equally is split into the 3 meals, but as half of the 0.5 units per kilo. So it's a really nice chart and gives people nice, easy means of working out what they need to be doing.
So Alex, for that chat, is that what you would suggest, that we would start him on a basal bolus kind of regime while he was in hospital?
Yes.
Yep. Okay.
Yep.
And I realise that's lots for everyone to take on. So Alex and I will provide, because can you obtain this just for anyone via the internet, Alex?
Yep. I can send this around.
Yep. So we can provide that afterwards. I can send that out to everyone, because I certainly feel like I need a bit of guidance with these people when they come in, because I sometimes think the insulin prescribing is a bit haphazard, because people just want to immediately get the sugar down. And you're saying thinking about it through the, the first 24, 48 hours of the admission is important. Yeah.
So the beauty of this particular methodology is that it is proactive to what people's needs are. So you're essentially doing a weight-based calculation to get a starting point, and then on a day or 24-hour basis, you recalculate according to what the total daily dose is, adjust the 50-50 split between basal and mealtime dosing, and put in a supplementary or correction amount as indicated down here by what the pre-mealtime capillary glucose is, what you want your target to be, and how much you need to bring it down back into that range again. And that gets added on to the mealtime rapid-acting dose with rapid-acting insulin. So I just caution everyone against using the term a sliding scale, because it really that should be reserved for insulin infusions only, whereby you're essentially constantly monitoring the capillary glucose levels, and you've got a insulin infusion that you're just adjusting the rate up and down according to what the overall requirements are, and you're not trying to do one insulin sort of added on to another and different peaks with it, etc.
Sharon, is there anything you'd like to add to Alex's explanation there?
Yep. Just when Alex was saying about food insulin and correction, they're added together and given at that time. So hopefully, we're not doing ad lib doses of insulin throughout the day. It's preprandial plus correction.
Yep.
And when Alex when you mentioned about the insulin infusion, they can go tricky when people are eating. So people should have their Lantus insulin while on insulin infusion. Plus, when they're eating, they can have some prandial insulin as well. Because otherwise, after a person's eaten, the blood sugars go up and the whole infusion is dialed up, and it can get quite. Is that what you would suggest, Alex?
Yeah, absolutely. And just reviewing our local protocol, it cautions against having people have any kind of food intake whilst they're on an insulin infusion. And so if you're anticipating that they might start eating, then you really need to stop the infusion at a set time. It's usually 1 hour before, and give a mealtime dose of subcutaneous insulin and see how they get on at that point in time.
Yep. So obviously, and if we had an ideal protocol to follow, like this Australian one, there'll be guidance around when to test sugars. But if we're providing that in our admission plan, Sharon, what guidance should we be giving the nurses about when to actually test these patients' sugars?
Definitely pre-meal, of course, to guide the dosing, and 2 to 3 hours after can give us a good idea of whether that amount of insulin was correct. At that meal time.
Sure.
Plus, I always like a pre-bed test.
Yep.
Have we got a safe level going to bed? And if a person's unwell and in hospital, a 2 a.m. test gives us some really good information as well.
Yeah. So that 2 o'clock one, that might be the time that they might dip quite low. So you're trying to capture that.
That's right.
That low.
Yeah.
And the action that we should take, obviously we treat that immediate low as required, but how might we change our overall insulin regime if people are getting those 2 o'clock lows, Sharon?
If they had a good going to bed level, which was at least 3 hours after their prandial evening insulin, then they are likely to be on too much long-acting Lantus insulin. So that Lantus dose should be reviewed.
Sure. Okay, and how long before a meal? Does it matter if they're checking 5 minutes before they meal and they give their preprandial insulin then, or should they be really checking, half an hour before a meal?
Pretty much just pre-meal. For a lot of type 1 folk now, we're suggesting they have their short-acting insulin 15 minutes before eating, and then that short-acting insulin's working a bit better before that blood sugar's starting to rise. But, I have seen accidents happen when people get distracted. They have their insulin, gets distracted, and they don't eat. So with the older folk, I like to say, have your food ready. Test your blood sugar, have your insulin, eat your meal.
Yeah, and there could be a delay, I guess, in the hospital delivery of meals too.
That's right.
Yeah, that's right. Gary, I might just come back to you. I think there's I see a few questions building up there.
Yeah, thanks, Matilda. I mean, there's a couple of sort of quite relevant questions on the topics that you're talking about. What one is, and I can see the logic of this, given the fact we don't like to carry unnecessary drugs in small places, is if can we get away with using Nova Rapid rather than Act Rapid for our insulin infusion? If holding Act Rapid really is now the only reason to keep Act Rapid hanging around, or is it just sort of habit that we keep doing that? And one other question too, which is probably fairly relevant to both of you, is around that initial calculation of your basal insulin, about whether or not that should be done on ideal body weight or on actual body weight.
Can I just answer about the Act Rapid insulin? My understanding is Act Rapid is the cheapest insulin that there is, and all IV insulin just works the same. Is that your understanding, Alex?
Yep, absolutely. And, if people just bear in mind that anyone on an insulin pump uses a rapid acting, so it's either Nova Rapid or Humalog in a pump. And the beauty of using the most rapid acting that you can get is that any change you make to your pump infusion rate has a rapid change in terms of its level in your bloodstream or in your body. So, yeah, it's neither here nor there really. If you're giving it intravenously, I don't see why they couldn't be exchanged. It's just not conventional, that's all. As far as dosing goes, to answer that second question there, Gary, that actual weight would be better, but not always, is probably better in the sense that those with much higher than ideal body weights are going to be considerably insulin resistant, and so predictably would need higher doses anyway. I think we talked earlier when I was showing the chart that a figure of 0.5 units per kilo was a good starting point for someone who's got average insulin sensitivity, who's unwell, being hospitalized, is going to be monitored intensively. Looking at some of the resources for people, as outpatients being started on insulin, often we'd start, someone on a lesser dose, something like 0.2 or 0.3 units per kilo, and just gradually build it up over a extended period of time, say a few weeks, according to what their needs are. So it's not an exact science, this, and I guess the point is to basically start with something that is towards the conservative end and basically keep a close eye on things and adjust up as needed, is probably the best way of explaining it to you. Your thoughts there, Sharon?
Yep, I agree wholeheartedly.
There's another question for both of you probably that feeds into that, and it's around the half-life of Lantus and how long it takes to reach a steady state, and whether we should be chasing adjustments every day, or whether or not we should be leaving a bit longer than that.
Definitely leaving a bit longer than that. It's really slow acting, and we generally say dose changes only every 3 or 4 days.
Right.
And the other thing on Lantus is that we say it's 24 hours action, but for most people it probably doesn't quite last 24 hours. So I prefer Lantus to be given at night. You get good coverage overnight, and then generally there's short-acting insulin through the day to help cover off when the Lantus is just tailoring out a wee bit.
Cool, thanks guys. I just was going to keep that same scenario in mind, but let's think about this chap that he comes into hospital, pneumonia again, but he's already on insulin. So he's on Lantus and Nova Rapid with meals, so a basal bolus regime. So can we just, he's got high sugars, he's a bit sick with his pneumonia. Can we just carry on with his usual regime? And if we do carry on with his usual regime, how are we best to adjust it to match these slightly higher sugars?
So we would get this man using his correction factor, which Alex put on a slide earlier. We work out 100 divided by the total daily dose. So if this chap was on something like 50 units, he's got a correction factor of 1 unit of insulin will drop his blood sugars 2 millimoles. That's just a very average example. So he will, if he's running blood sugars above where he wants them, he'll add on that correction insulin with his prandial insulin.
Yep.
And we can give him a written scale to help with that. You know, if his blood sugar's that, then he'll have this much.
Yep. So for, I mean, everyone's individual, but say for this chap, what kind of sugars would you suggest he should be aiming for, you know, during his admission with an acute illness? What kind of range would you be happy with?
I think we're generally going for, if he's an inpatient, we're going for blood sugars definitely under 10.
Okay, so say he is eating and drinking, he sits down, he does his sugar before the meal, it's 20, then he's trying to bring his blood glucose down by 10, so he uses his correction factor to work out how many units of his short-acting insulin. Is that correct, Sharon?
That's correct. So he'll have his food insulin plus a correction of an extra 5 units.
Okay. And what would I do with his Lantus dose for that first day in hospital?
It's a tricky one. If it's, it could be increased. It could be increased a little bit, I think, couldn't it, Alex?
Yep. You're probably best to leave it for the first day and try and work out what your total daily dose has been 24 hours later, and then, you know, look to try and split the proportions back up again of what that total daily dose is, and work out how much additional Lantus that therefore means is needed, and what the higher amounts of prandial insulin are that you need to be using, and then still, if needed, add on a correction factor until essentially you have mealtime doses that are managing the need at that time.
Yep. So would he use the correction factor, or the dose that he calculates using the correction fraction, would he add that onto his usual pre-prandial dosing, or would that replace his usual pre-prandial dosing?
Add it on.
Add it on. Okay. What happens, Sharon, what advice would you give to me if I called you and said this man was coming in, he had pneumonia, but he also had an acute kidney injury and his creatinine was double its usual amount? Would that influence how I might prescribe his insulin?
Yes, I'm quite a bit more careful, conservative with insulin with people with deteriorating renal function.
Yep.
Just because insulin's not supposed to be renally excreted, but we do know that it accumulates and people are more at risk of hypoglycemia.
Okay, sure. And would you agree with that, Alex? You'd change it slightly?
Yeah, look, it all depends on the overall context and situation and the sort of degree of physiological stress that we're seeing, because that's probably going to be the main driver as to how much need for insulin there is at any one time. And yeah, I guess that in the same way that many other drugs we give, you know, can be problematic in acute kidney injury, you know, we just need to be mindful of that with insulins too.
Sure. So if I'm getting this right, the chap who was not on insulin to begin with, we're going to start him on a basal bolus regime, and we're going to use some kind of protocol to guide us in our diagnosing, and that's going to be weight-based. And then we're going to look at him over 24, 48 hours and adjust that. But if we're dealing with the chap who's already on insulin, we're going to carry on with his basal bolus, and we can use a correction factor to adjust his insulin pre-meal to try and level things out. Would that be a fair summary?
Yes.
Yep. Okay. So what happens if this man was not quite well enough to come into hospital, and we said, look, I think we can put you on oral antibiotics and send you home, but your sugars definitely are running a bit high, and he says, what on earth am I going to do about my diabetes when I'm at home?
What we don't know about this person is what is his HbA1c.
I'm going to take that he's middle of the road. You know, his HbA1c is 60 to 70.
So I would actually suggest that a few days on antibiotics and he's going to be a lot better. and his blood sugars are going to settle likely.
Yep.
So it depends how acute his blood sugars are.
Yep.
And is that a problem? Are we going to start some medication to get him over that? Or are we going to wait a couple of days for it to settle?
Yeah, so you kind of got to think about, is it clinically significant? Is it all right for him just to go a few days with his sugars up a little bit rather than fiddling around with his insulin?
Yeah. And how high are they?
Yeah. Would you agree with that, Alex?
Yeah, I think that's a fair comment. I think you just need to bring into context the sort of supports that this person has and ability to look after themselves, and perhaps whether or not they can get some monitoring done in the interim between now and their next healthcare contact as well, to just see where things are at.
Yep. Gary, are there any questions related to that sort of that case drawn to an end? Any questions that have cropped up?
There's a couple there. There's one question around, particularly still a few patients around who are not on basal bolus regimes, but are on mixed insulin regimes, like twice daily sort of insulin. And you've given a really nice sort of logical approach to the person who's on the basal bolus regime. But have you got any advice for the patient who's perhaps on that simpler BD mixed insulin regime? Or would you change them onto a basal bolus temporarily?
Personally, I try and keep things really simple. Try just not to make overcomplicate things. So we can quite safely do a TDS mixed insulin. So we could add in some midday insulin there, or increase the BD dose that the person's on temporarily to get them over this bump. And infrequently, perhaps I would add in a short-acting insulin, but then you've got to be confident that that person's not going to mix up their insulins. It's just about keeping it simple and what can that person manage well at home.
Can I just interrupt and clarify? This is about my terrible area of weakness is all these insulin business. So when you say mixed insulin, can you just clarify exactly what the mixture is? What types and duration of action are in the mixed?
So we'd often use Novamix 30, which is 30% short-acting, 70% longer-acting. It's not 24-hour, but the 12-hour, like Protophane type. That's your Novamix. Or your Humalog Mix 25, which is 25% Humalog, short-acting, 75% of the Humulin longer-acting.
Yep.
So that you see that will cover about 8 hours. So that's why it's a BD insulin, and it's given with breakfast and with dinner.
Yep.
But if we want to bump up the dose, we could add in a lunchtime dose just to bump it up.
Sure. And that you're starting, this is sort of going sideways, but you're starting your diabetics on those mixed insulins if they're starting to get blips around meal times, like their sugars are starting to blip up around meal times quite significantly.
Yeah.
Okay.
So we use the blood glucose profile to choose which insulin.
Mm-hmm.
If they've got consistent high blood sugars, just a long-acting like Lantus will probably be satisfactory. If they're having a postprandial rise, we'd consider adding in a short-acting insulin.
Mm-hmm.
But then that becomes quite, people have to do a lot of monitoring, etc., and injecting. A BD mix is a lot simpler for people.
Yep.
You get less optimal blood sugars, but it's much simpler and often much more tolerable.
Gary, any further things there?
There's one other question which comes back to this issue of metformin, and I guess comes back to that threshold that you have, sort of how sick does a patient have to be before you stop their metformin, which I get a feeling has actually changed over the years. We're a little bit braver about keeping it going than what we used to be in the past. But if you get someone who comes in with an intercurrent illness and their blood sugars aren't high, but they are on metformin, do you have a sort of rough threshold at which point you would actually temporarily stop that metformin and replace it with some insulin, even though their sugars aren't high at that time? It's probably not an easy question, that one.
No, it's a good question, Gary, because it's a real life scenario. I think if you are consistently seeing blood sugars in the mid-teens or higher, then you would probably need to look at getting on and giving some insulin to get that under control. Depending on what the trajectory of this person's illness was appearing to be as well. If it looked like they were going to be a whole lot better in 24 hours time, with much less physiologic stress driving their sugars to be high, and it was only sitting at sort of 10 to 12, you might just hang in there for that period of time. I think you've got to put it in the wider context of the situation, really. Sharon?
Well, thanks, Alex. Sorry, Sharon. Yep.
No, I agree.
Cool. So I think we'll move away just from that sort of acute admission time, and kind of to the diabetic who you got on the ward. And often I'm not the person necessarily who's going to be starting somebody on insulin for the long term, but I think it's important for hospital doctors to, have an ability to sort of recognise the patient that should be started on insulin. They've been on oral agents, but it's time to go into insulin. I just wondered, Sharon, perhaps if you could comment on when is it time for someone for a type 2 diabetic to be going on into insulin, and what's the clues for us as the hospital doctor about that time to make that transition?
I would say not reaching target HbA1c, and they've been on maximum orals for a period of time. And so that would lead us to the question, what is the target HbA1c, which for a young person might be 50 millimoles per mole, and for an older person, we might shift that to 64. So we have more relaxed targets as we get older. And for an elderly, frail person, we may want it quite a bit weaker than 64 even, because we have a very low tolerance for hypoglycemia in the elderly. So generally not meeting target maximum orals, we'd be considering starting insulin.
Yeah. And I think one of the things that you commented to me the other day, that maximum orals will differ between people because of what they'll tolerate as well.
That's right.
Yeah. And what sort of is the most common reason that you see people not able to push up to the maximum doses of oral agents?
The very most common thing is intolerance to metformin.
Yeah.
So that causes a lot of gut upset, and often people don't talk about it, but we should always be asking, how's your tummy, if they're on metformin, because it causes a lot of grief. And Alex is probably going to talk about the newer medications. In the up till now, we've mainly used sulfonylureas and metformin, but we're not using sulfonylureas much anymore at all.
And when you make that decision to go onto insulin, and someone's already on metformin, do you stop the metformin, or you tend to keep going with it?
Definitely keep going with it. I explain to people that it gets the insulin working better.
Okay.
So they're likely to need a lot more insulin if we stop the metformin. Keep the metformin going, add on some insulin, and we just start low and titrate it up.
Sure. And what's your usual sort of, what do you normally start with agent-wise for the type 2 diabetic going onto insulin?
As people see on TV, the one everybody knows about is Lantus, but we want a blood glucose profile first. So if their blood sugars are consistently elevated through the day, then Lantus will be suitable. But if they're having a significant postprandial rise, it may be that some short-acting insulin might work better. So it's really studying those blood sugars and seeing what is going to suit best. But often, people are very anxious about starting insulin. Lantus is the simplest one to start. It's once a day, at bedtime, not with food, and low risk of hypoglycemia. So sometimes it's a kind, gentle way just to start, 1 month of Lantus to get them going.
And I think that that graph that Alex showed us earlier really illustrates that point with the type 2 diabetic, that I think I didn't quite understand this till now, that their sugars are just running chronically kind of high, as opposed to the type 1 diabetic who is shooting up and down, and you're having to counter that with short-acting insulin frequently throughout the day.
That's right. The risk is if people just use Lantus and they're having a considerable postprandial rise, the risk can be of increasing the Lantus to the extent where they'll sooner or later start having hypos at night. So that's when we have to look at a different process.
So you can actually end up not really treating the issue that you're trying to, and then creating harm.
That's right.
At night time. I'm conscious of the time, so please, I sort of think we've still got a wee bit of ground to cover, and I'm still learning, so I'm going to carry on, but please feel free to go if you need to. I just see that there are questions coming through, and Gary, anything relevant to what we were just exploring there with Sharon?
I think just moving on to that discussion about the new agents might cover some of those things.
Yep, sure. So maybe Alex, if we could just really briefly recap the agents that we use already, like one sentence each maybe, and then move on to comment about some of those newer agents.
So metformin's still the sort of the mainstay of managing insulin resistance, or which is the main pathophysiology in type 2 diabetes. And this diagram seeks to try and just explain some of the effects that metformin has on the body. It reduces the amount of glucose that's absorbed from the gut. It helps the body to utilize it more effectively, and it increases by way of increasing the sensitivity to insulin in the peripheral cells of the body. It also helps to shut down part of the pathophysiology of gluconeogenesis and lipogenesis, and therefore help with the sort of the underlying reason why sugars are getting out of control. What I'll move to next is just that metformin really needs to be kept in very much in conjunction with non-pharmacological interventions, and these are still really the foundation of what we need to be doing to help sort of break that pathophysiology, if we can, by helping people to eat, more sensible food that produces less glycemia, and also to exercise more, which helps with that insulin sensitivity issue as well. It's perhaps something that I've seen not be done all that well in acute hospital settings often, but we always need to be mindful of the opportunities that we have to just give some brief advice even about people managing their issue by lifestyle interventions, and getting them off to have some CVD risk assessment done, or a diabetic annual review, a completely free assessment that patient can have to try and get things back on track again. I'll just touch now. Is now a good time to talk about some of the newer drugs, Matilda?
Perfect.
Yeah. So the incretin pathways is represented by this diagram here. So the glucagon-like peptide 1 agonists essentially are glucagon-like peptide 1 is a hormone which our bodies produce, and it helps to increase the production of insulin from our beta cells when there is glucose there that needs the attention of the insulin. So it's really good because it works when it needs to, but it doesn't produce sort of the adverse effects of just simply giving more and more insulin to somebody, such as hypoglycemia, for example, to nearly the same extent. So it also helps with slowing gastric emptying, and one of the problems it has that they have that nausea can be a common issue, but it does help achieve weight loss. And in New Zealand, currently, liraglutide, one of our GLP-1 agonists, is licensed only for weight loss. We've got exenatide, which is licensed for type 2 diabetes, but is not yet funded. They probably reduce CVD events. It hasn't yet been portrayed in the data in the literature yet, but I guess these are going to be coming on scene soon, no doubt. And they're injection only, which is one other downside to them, but they're a much better means of trying to get good control in the longer run. The DPP4 enzyme is basically just an inactivator of the GLP-1. So these drugs, these inhibitors, seek to try and stop the GLP-1 being degraded. And so we do have one of these drugs currently available and subsidised called vildagliptin. We just have to be careful about liver impairment with the gliptin class. They have a sort of similar effect to what the GLP-1 agonists do, just not quite as potent. They don't really seem to produce any impact on CVD outcomes, so not quite as good. They also maybe have some concerns around an increased potential for causing for pancreatitis to occur, but again, it's early days. We'll just go on.
Can I just interrupt you, Alex?
Yeah.
So the one that's available in New Zealand is, do we say vildagliptin?
Correct. Yeah.
And
Also known as Galvus.
Galvus. I was just wondering if Sharon wanted to comment if many of her patients were on that, and who can access that drug.
Yeah, it's funded, and it is useful, and the combination is Galvamet as well. So that's metformin 1 gram plus vildagliptin 50 milligrams. So that's, instead of 3 tablets, that's one. So that works really well for people.
And that's not special authority. That's people can just be on that.
Yeah.
Yeah. Many side effects, or is it reasonably well tolerated?
Vildagliptin's well tolerated. It's still just the metformin side effect.
Yep. And have you clinically, like anecdotally, much weight loss that you're seeing with the addition of that agent?
I'm actually seeing some quite good results with it.
Yep.
Yeah.
Cool. Thanks, Sharon.
Yeah, so just moving on, another class, we're just about done. So the SGLT2 inhibitors are probably the big new category that's coming onto the scene now. So we've got dapagliflozin registered in New Zealand, not yet funded. It's making some quite big waves in the literature worldwide, insofar as there's clear benefits to CVD outcomes and chronic kidney disease, especially if there's established proteinuria, which of course is, the hallmark of diabetic nephropathy. So these have multi-system potential benefits for people, and it also benefits and is seen now as an add-on therapy for heart failure, independent of diabetes as well. It's an interesting category of medication that it works to basically help the kidneys to excrete excess glucose from the body. And so with that comes a problem in terms of a higher potential to have genitourinary thrush and an increased incidence of urinary tract infections. And the other thing I think all of us need to be just aware of with these new meds coming in, and particularly this category, the SGLT2 inhibitors, they can produce this obscure condition called euglycemic diabetic ketoacidosis, where people with normal blood glucose levels, in the presence of becoming a bit dehydrated with that osmotic diuresis issue going on, can develop a DKA and become really critically ill as a result. So it's something that we're all just going to need to be mindful of when we start seeing people on these drugs and with acute illnesses.
Alex, did you say that class they're called flozins?
Yeah, well, that's it's the end part of all of the different drugs of that category here.
Yeah. So Sue had written a question: will flozins change our insulin prescribing?
Yeah, I mean, I've put up just now on the slide the remaining groups of anti-diabetic agents being sulfonylureas, glitazones, acarbose, etc. And probably looking at overseas literature, the sulfonylureas are probably going to end up being sort of phased out in time, because they're just not as good and more prone to problems than some of these newer agents, which are more directly acting on the pathophysiology as well. So I expect that we'll see people taking combinations of metformin, GLP-1 agonist, SGLT2 inhibitor all at once, and perhaps avoiding the need for supplementary insulin with that. They can be used with insulin to some extent, but I guess the real life experience with them is still limited at the moment.
Yeah, and I mean, I think that's why we were conscious to bring them up tonight. We were aware that it's a lot of information to take on board, but we felt like, you know, we need to be introduced to these ideas and these drugs, even though we may not necessarily be starting them, the initial prescribers, but we will be soon seeing patients who are on them.
Yep.
Alex, is there anything further that you want to say with regard that? And I'll check in. Gary, any other questions that have popped up?
There's just one which is going backwards a little bit, but it is a question I'd actually thought that Sharon had answered earlier on about the timing of day for Lantus, in which you suggest that it's better to give in the evening because not quite full 24-hour cover from it, Sharon. But what about in that situation where you are just giving someone Lantus and nothing else?
Lantus can be any time, really, and so it's the most suitable time for the person. And the time when they're least likely to forget it. So often I think for older people, perhaps morning might be better. So just the safest time for the person, it's okay.
Yeah. So Sharon, I think I'll give you the final word, because I think the one thing we haven't touched on, it has been quite medication oriented, and Alex has brought up the aspects of diabetes management that are so important but often overlooked with regard to exercise and diet. But I think something you mentioned to us was sort of your relationship with your patients and the approach that you take is so crucial as well. I just wondered if you wanted to comment on that.
As Alex mentioned, you know, diabetes is just relentless for people. It's not like a lot of conditions where people will get better. You know, it's hard work for them, and often they come to clinic and will say, oh, this is bad, you know, if the HbA1c is too high. We just need to walk beside them and know what struggles they've got going on in their lives, and just support them the best we can, you know. And yeah, we all have bad days.
Well said. Alex, any other final comments?
No, I think we've it's good to raise that again in the discussion there, Matilda, of the non-pharmacological management of things, and I guess especially up where we are, central North Highland, large Māori population, and it's important to maintain a focus on trying to achieve equity as well. Would be the other really important thing to just keep in mind with how we're managing these situations, and there's certain Māori health aspects that are quite critical to understand in diabetes management, as far as longer term outlooks for people and what they want from their management. And so I think at the end of the day, like, really good consulting skills of trying to sound people out for what they want to achieve with their diabetes management is really important. And I think we hopefully do that reasonably well in the rural hospitals normally.
Thanks, Alex. So just final reminder to fill out the survey, the links there in the chat box, and that will provide your medical council number as well. So that brings our webinar to an end. So thank you so much to Sharon and Alex. I've learned so much just even in the preparation for this webinar, identified quite a few gaps in my knowledge, learned even more tonight, and I really appreciate the time and energy that you've both put into this. And Sharon, really awesome to have your nursing expertise. It's really sort of grounding and quite real, and I think you have to recognise that you do most of the work out there with the diabetics, so we've got lots to learn from you. Thanks to Gary and Rory for your help, and thank you to you all attending and lots of questions tonight. I hope we got to all your questions. Feel free to send me any that didn't get answered, and I can pass them on to Sharon and Alex. And just remember that these are recorded, and we'll put it up on Rory's blog shortly on Leaning on Fence Posts. So ka kite anō.